Okay, well, thank you for this introduction. And basically, I've been asked to present how MRI is used in acute ischemic stroke. We use MRI very extensively at the Cleveland Clinic. I do not believe it is the only way to image stroke. I think there are many different possibilities, but I'm going to just highlight why this is a good modality for acute ischemic stroke evaluation. So MRI is utilized actually seldomly, but the paradigms where it is actually most useful are when patients present with unknown time of stroke symptom onset, or when patients are outside the regular established window of 6 hours. Then there are also additional patients where MRI is very useful, and those are patients who cannot receive contrast easily. So patients who have renal failure or have a contrast allergy, and you would not want to give these patients contrast unless you knew that there was a large vessel occlusion that you were actually going to do something interventionally. And finally, there are clinical dilemmas that are pretty much impossible to solve on CT alone. And only MRI can really show these tiny little strokes, and also it's very good at ruling out all these different stroke mimics, including seizures, but also malingering syndrome, things like that. So why is MRI important? Well, first, the most important part about stroke is the fact that when a stroke happens, we start with a vessel that is occluded, and then it goes into basically the tissue starts dying, and it starts as the core. However, there's a lot of tissue that's underperfused, and that is tissue that is potentially salvageable. And what is important is for us, when a patient presents, regardless of the time of onset, we would like to know exactly how much tissue has died and how much tissue is still at risk of further dying. If we had this information, we would have all the information that we need to decide whether we're going to do an intervention. Because if you think about the tissue that has died, this core represents the risk of the procedure. That's, if you open up this vessel and this tissue has already died, that's the tissue that is most likely to bleed. The penumbra, the tissue at risk of further dying, is the benefit. That's the tissue that we're going to save. So if you had some kind of an imaging modality that would show you this, then you would have your answers very, very easily. Unfortunately, none of the modalities that we have right now are perfect at this, but MRI can be useful, as I was saying. So the reason behind all of this is our regular windows. I've shown this slide before. Our regular windows are based on an average patient population. And if all patients were kind of following this curve with all this data was clustered, then we would really, all we would really need to go by is the time. However, it doesn't look like this, and we would like to pull out the patients that can still benefit from thrombectomy way farther out, and we have the new DAWN trial that's actually supports this, where before we really, it was hard to consider patients that were beyond 6 hours, but now we have actual undisputed proof that there are some patients, if they're picked out well, either through CT perfusion or through MRI, they can really benefit from mechanical thrombectomy up to 24 hours. So why is MRI good? Well, MRI basically provides diffusion-weighted imaging, and this is a type of image that is very, very sensitive to strokes. So in animal models, diffusion-weighted images become positive only after 20 minutes of vascular occlusion. So no other modality can do this. Why does this work? Well, basically, diffusion-weighted imaging, what it does is basically it images water molecule flow. So you're imaging protons. And when you're getting a diffusion-weighted image, what happens is you're exciting protons in a tissue of brain by setting these very, very strong gradients. You're waiting a little bit, and then you re-excite those protons, and you try to get a signal. protons that are moving away freely, when you re-excite them, when you try to realign them, are going to move away from the imaging. They're actually going to be out of phase, so they will give you no signal. So that is basically what you get in the ventricles here. Protons that are kind of intermediately moving, that would be the normal brain tissue. And this bright signal here represents water that is actually trapped within the cell. It's not moving freely. And this is not just a qualitative measure. We actually have quantitative data that we can get from these images that show you exactly how much water is moving in what direction. And again, this corresponds to our basically this is an ADC map, so it's the correlate to diffusion-weighted images, and the ADC values decrease with brain tissue ischemia, and this is directly related to the cytotoxic edema, and I'll explain that. So basically what happens is, normally in cells you have the sodium-potassium pump, and for every 2 potassiums that are pumped into the cell, 3 sodiums are pumped out. So there is basically this ionic gradient, and the pump requires ATP for it to work. However, when we interrupt blood flow, we're not providing sugar, we're not providing oxygen, and the ATP pump fails, and so all of a sudden this gradient is lost, and water rushes into the cell. Water is then trapped in the cell and does not diffuse easily, and so we have a very high signal on the diffusion-weighted images and low signal on the apparent diffusion coefficient maps. How does this work in terms of actually what happens, what is the fate of the tissue that has a certain ADC value, so a certain amount of diffusion? And Chelsea and Kidwell published in Stroke this model where they actually followed tissue after an ischemic stroke, both with intervention and without intervention, and they found out that these ADC values were actually related to what happens to a pixel of tissue that initially had a certain ADC, basically apparent diffusion coefficient value. And ideally, what you would really want is you would want to have 3 peaks. One for tissue that goes on to hemorrhage, another peak for tissue that goes on to infarction, and then another peak for penumbra. That is actually not so. There is overlap between these things, but this actually does show that if you have a value of, let's say 400, that this pixel is more likely to go onto hemorrhage than and infarction together, or if you have then a pixel that basically has an apparent diffusion coefficient of 1,000 or so. So when people looked at this, they asked the question, what happens? Can you actually have images that are diffusion positive, but can you actually not have a stroke down the road? Can these things be reversible? And it turns out that yes, just because you have something positive on diffusion, if you recanalize a patient, the diffusion abnormality can normalize. So that would kind of lower the utility of MRI, because you can't tell 100% just from the diffusion that this tissue is going to go on and infarct. And so they actually showed this example where a patient had a diffusion abnormality, and you can see it on the DWI images and the ADC images. But afterwards, after an intervention was made, this was reversed. However, it turns out that this reversal actually is kind of like a pseudo-reversal. The cells are full of fluid, and the fluid is trapped. And actually, when the cells sometimes go on to necrosis, the diffusion can actually increase. So this is not necessarily, a diffusion reversibility a couple of days later doesn't mean that tissue is alive. And another study was done that was actually more oriented to the functional outcome and how these things work. And this was recently published in Stroke in 2014, where they took 110 patients and they did diffusion-weighted imaging before thrombectomy. And then they looked to see if there was diffusion-weighted reversibility, meaning that lesions that were positive on MRI, did that actually change and go back and become a normal pixel? And it turns out that yes, that this happens about 1/3 of the time, but it's actually not really functionally meaningful. Most of these reversible lesions actually were small, so this happens often in patients, but the reversibility is very small. It only involves about 3 to 5 milliliters, and then basically the reversibility is transient. So the reversibility does not represent actually tissue being viable. It's just an imaging characteristics where things are diffusing more now, but the cells are not necessarily going on to live. And they found that they were unable to document any kind of association between a transient DWI reversal and favorable clinical outcomes. So what does that mean for us? In general, if you have a patient who comes in and they are DWI positive on MRI, then that is pretty much going to be the infarct. That's basically what it means functionally. Okay, so when would we use MRI? We don't want to use MRI all the time because of, as you said, cost, and also there might be some other barriers, such as patients with metal, all kinds of things. However, it is very useful for patients that present outside the 6-hour window, and also if their time of onset of the stroke is unknown, and for wake-up strokes, which again, we don't know when their time of onset is started. And that's pretty much what we do at the clinic. So for patients who present within 4.5 hours, they would get a CT-CTA. If there's if there's no hemorrhage on the CT, then they go on to IVTPA, and if the CTA shows a large vessel occlusion, they would get TPA. For 4.5 to 6 hours, they would get a CT-CTA only. They would obviously not be eligible for IVTPA, but they would go on to mechanical thrombectomy if they have a large vessel occlusion. But for patients that are outside the 6 hours, it's very helpful to get MRI images because it can pick out the patients that already have had a completed large infarct versus the patients who have had a very, have a very small infarct and they can still benefit from thrombectomy. So that's the major use of MRI is actually these diffusion-weighted images. Another use that I had mentioned was for patients who cannot get contrast or who have a contrast allergy or they might have renal failure. You can get a great angiogram with an MR without any kind of contrast. So this is an example of one of the time-of-flight MRAs, which shows basically a right MCA occlusion, and you can pick that out right away. And then the other thing is for stroke mimics. As I was saying, MRI is really good for these cases that present a dilemma. So for example, a patient who has a thalamic infarct, clinically, they could have very, very bizarre signs, and you don't really know what's going on. Are they making it up? Are they seizing? Is there something else going on, some kind of viral infection, But an MRI will show you right away that there's a stroke here in the thalamus. And it's very sensitive, so it can actually show these tiny additional infarcts that you wouldn't really consider otherwise. You have no way of knowing that they're there because they would be clinically silent, such as this infarct in the frontal lobe. So in terms of metal, not all stroke patients, or actually a lot of stroke patients who present, they're not able to talk or they're confused. They have problems. So and there may not be really good history. Their family might be not around. So how do we deal with this? How do we actually get these people to the MRI? So with a very, very low radiation dose, if a patient is on a CT scanner and they have a large vessel occlusion already on the CT, but they're beyond the 6-hour window or their time of onset is unknown, and if there is no one around to ask whether they have any kind of metal implants to clear them for the MRI, we can do this whole body scout CT. It's very little radiation. It takes seconds. And if there's any metal, we pick it right up. So these patients can be triaged that way. And also, pacemakers. More and more people are getting pacemakers these days. And it's estimated that actually 75% of the population by the year 2020 will have a pacemaker. And a lot of those actually will need an MRI. So people have recognized this a long time ago, and most of these pacemakers actually since 2008 have been actually produced such that they're safe in the MRI, okay? And almost all the major companies now have an FDA-approved pacemaker that is MRI safe. Obviously, not all of them are, but if you have this information, if you can get it quickly, you can get an MRI in patients with a pacemaker. So, so let me show you a couple of cases. This is a case actually that I showed last time, but it's actually it goes along with this. So we have a 95-year-old female. She has a past medical history of atrial fibrillation, all kinds of risk factors for stroke. And last known well was at 9:30 the night before. And she wakes up at 8:30 with aphasia, right-sided weakness, and right-sided loss of sensation. And she's in the Cleveland Clinic ED at 9:30 a.m. What do we do? You know, she's outside any kind of window. So we do a CT scan, which is negative for hemorrhage, but it does show these densities in the middle cerebral artery. And sure enough, distally out here, you know, in the M1, M2 region, she has a clot. But can we do anything? You know, it doesn't look, if you looked at aspect score, you know, they probably, you know, this probably would be a go, but you don't really know what's going on with this patient. It's been a long time since her last known well. Well, we do an MRI, and very quickly we find out exactly what has infarcted. So we have an infarct in the temporal lobe. This is diffusion-weighted images. This sequence takes about 4 minutes, and that's really all we need. And usually, you know, you can get this, basically it takes more time to transfer them to the MRI than it actually does to take the sequences. So within the time that we're setting up, we're already getting these images. By the time, you know, we're getting all our flush bags ready and everything, we have these images and we can make a decision. And this is a small infarct. However, she's not moving her right side, you know, so clinically, we know that she has a very large perfusion deficit. Her NIH stroke scale is high, and so we don't need to get any additional imaging. I don't need to get perfusion because I know clinically she's lost a lot of function, and this is going to be a large infarct if we don't do something. So, you know, she goes on to mechanical thrombectomy. These are images from her thrombectomy. We cross the clot, open it up, and this is her CT afterward. So she did not go on to have a major MCA infarct. She recovered movement on the right side, and actually her aphasia most reversed. She still had some word-finding difficulty, but it certainly improved. So this would be a patient who normally would not be eligible for anything, but because of the MRI and the diffusion-weighted images, we were able to intervene. Another patient, she's a 77-year-old female, again, lots of risk factors for stroke, and she was found by a friend in the morning, but we have no idea. She can't speak, so we have no idea when all these things started. And she was also allergic to contrast. So what do? Well, we can actually get an MRA. She had a negative non-contrast CT. We can get an MRA and an MR diffusion-weighted images. The whole thing takes about 10 minutes, and it shows that there is a occlusion of the left M1 segment, and the diffusion-weighted imaging is completely negative. So this is the best possible scenario because there is no core. We can save everything here if we open up this vessel. And so, you know, she goes on to mechanical thrombectomy. We cross the lesion with a solitaire stent. We pull out the clot. This is before and after. This is the lateral before and after. And this is her MRI, diffusion-weighted images after the intervention. So clinically, she has 0 deficits. This shows us that she has a tiny, tiny stroke here, and this is probably not related to her original occlusion. It was basically when we were taking out the clot, a tiny, tiny piece went into a very, very small vessel. You know, clinically, she'll never know that this happened, but we know by MRI, by the sensitivity of it, that she had a tiny, tiny stroke. Okay. So, yeah, so in conclusion, MRI is very helpful because it is pretty much the best modality which is able to pick out the tissue that has already infarcted. The tissue that's at risk, you get that from the patient's clinical exam. And this has been validated actually recently. I was very excited. I've been doing this for many, many years, this protocol. However, I was very excited that this was validated recently in the DAWN trial, which basically shows that you should be intervening on patients up to 24 hours from symptom onset if when they present, if their core is less than 50 cc's. I would go even further than that. It actually really doesn't matter when the symptoms started. It makes no difference. The only thing that really matters is the tissue, the vessel that is occluded, the patient's deficit, and how much of a stroke on DWI they actually have. If the deficit is large and the core is small, then that's a go, and time has really no meaning.